This is Let's Read, Indigenous Health Agent Professionalization Program in the Alto Rio Negro region. And it's a report written by Social Innovation and Health Initiative. We're going to scroll past the table of contents abbreviations to case introduction. The Indigenous Community Health Agent Professionalization Program, or ICHAP, aims to enhance healthcare services in remote Indigenous communities in Brazil by incorporating the cultural underpinnings and voices of Indigenous peoples and their local community health agents. It's the first community health worker program that has developed a formalized training approach tailored to the contextual and cultural realities of these Indigenous peoples. In a context where Indigenous peoples are often severely marginalized, recognizing and equipping their local health agents helps ensure that the healthcare services delivered to these remote Indigenous communities are both high quality and culturally appropriate. The training program uniquely blends traditional medicine, biomedical approaches, and general education. The first cycle of the program, running from 2009 to 2015, trained and professionalized 189 Indigenous health agents. Not only has ICHAP raised awareness on the role of Indigenous community health agents, but also the qualifications that these health agents gain on completion of the education program has enabled them to receive a salary for the work they do. This case study illustrates how in countries with marginalized or distinct cultural population groups, a deep understanding of these communities' values and beliefs toward health and well-being provides insight into how health systems should be adapted or redesigned to allow for culturally respectful care that is truly person-centered. It shows how traditional community knowledge can be leveraged and integrated successfully along with biomedical approaches in a structured and cohesive way. Quote, "It was the first time somebody was trying in a serious way to join tradition and biomedicine in Brazil," end quote. We're going to go past the profile and go to number 2, challenges. Globally, there are an estimated 370 million Indigenous peoples resident in 70 countries. The term Indigenous peoples represents groups such as First Nations people of Canada, the Aboriginal and Torres Strait Islanders of Australia, and the variety of ethnic groups found in Latin American countries. They are characterized through their self-identification as Indigenous peoples. They have historical continuity with pre-colonial societies, strong links to territories and natural resources, distinct cultural beliefs and languages, and are resolved to maintain and reproduce their ancestral environment as distinct peoples and communities. Indigenous peoples across the world are some of the most marginalized in society. They are often poor, less educated, and have worse health indicators than the general population. Over decades, Indigenous people have been subjected to institutional and legal discrimination that has threatened their land, culture, and traditional knowledge systems. These knowledge systems are considered the foundation of community life as they provide the guiding principles for decision-making, approaches to health education, and the management of natural resources. In Latin America, Indigenous people represent over 400 different ethnic groups and comprise 10% of the total population. The 2010 Brazilian census estimated the presence of approximately 900,000 Indigenous Brazilians. Indigenous communities live in 600 federally recognized reserves covering 12% of the land area of Brazil. The majority of the reserves are located in the Amazon. The Brazilian Indigenous peoples face several challenges. They have higher rates of infectious diseases and, due to changes in their dietary patterns, non-communicable diseases are increasing. A total of 30.3% of Indigenous women are overweight and 15.8% are classified as obese. Recent data published on child health indicators shows a difference in the health of Indigenous children as compared to the benchmark general population. Infant mortality is 40.6% compared to 15.3%, and the under 5 stunting is 25.7% as compared to 7%. Socioeconomic and sanitation indicators provide further insight as into the determinants of health, with 63.3% of Indigenous households having an income below the Brazilian minimum salary as compared to 41.5% of non-Indigenous households. Only 22.1% of adults have completed secondary school as compared to 40.3% of the general population. There remain major deficiencies in public services such as sanitation, provision of safe drinking water, and waste management. Delivery of health services to Indigenous peoples has a complex history within the formal healthcare system in Brazil. The adoption of the new constitution in 1988 signaled a change in many official structures and brought into existence the unified health system. The constitution also signaled an important advance in the recognition of Indigenous collective rights. Prior to 1988, Indigenous health was under the control of the National Indian Foundation, FUNAI, and until the mid-1990s, Indigenous health was delivered by rotating healthcare teams. By 1999, the responsibility for Indigenous health was transferred to the Brazilian Ministry of Health under a subsystem for Indigenous health. or SASI. Under the 2002 National Policy for the Health of Indigenous Peoples, the subsystem was restructured to deliver services through geographically organized, specialized Indigenous sanitary districts coordinated by the National Health Foundation. Districts were responsible for the organization and provision of services predominantly through non-governmental providers. Due to technical deficiencies, management problems, and accusations of corruptions within FUNASA, which is the National Health Foundation, protests were held by Indigenous movements and other Indigenous groups. Finally, in the late 2010, the government transitioned the responsibility from FUNASA to the newly created Secretariat for Indigenous Health, or SESAI, to ensure higher quality while promoting management autonomy at the district level. Service delivery continues to occur through the DESI, which is the District Special Indigenous Sanitary Districts, and is structured according to 3 levels of care. You have health posts at village level supported by Indigenous health agents, comprehensive medical units comprised of multidisciplinary health teams at selected geographic locations or poles, and specialized referral care at Indian health houses, or called kasai, established within urban areas. Despite the attempts made, multiple health service delivery challenges continue to exist in Indigenous communities. Distance, the location of health facilities, and the isolation of Indigenous communities pose major barriers for accessing health services. If a patient requires specialized care, it could easily take up to 4 days to reach an Indian health house. Another key issue is the lack of cultural sensitivity and appropriateness of care delivery. The health system in Brazil is shaped according to Western scientific and liberal values. This is in stark contrast to the perception of health and illness defined by Indigenous people, who define well-being more broadly than merely the absence of disease. Well-being is considered to be the achievement of a balance between the physical, mental, emotional, and spiritual dimensions of life. This balance extends beyond individual health and healing and includes the ability to live in harmony with the environment, the community, and the spirit world. Indigenous traditional medicine practices are passed down through generations and heavily depend on the land, food, and availability of medicinal plants. In contrast to medical practices, which focus on the individual, Indigenous health systems are community-based. Healing involves a collective experience of consultation and public process that includes offerings and gatherings. The Brazilian National Policy for the Health of Indigenous People calls for a complementary and differentiated model of service organization that takes into account the Indigenous cultural perceptions of health and well-being. The fusion of Western and traditional medicine practices has yet to occur, and there's been a lack of recognition by official health authorities on the role of Indigenous health workers. Despite Indigenous community health agents' vast knowledge in traditional medicine and their embeddedness in the communities, the role of Indigenous health agents as part of the Indigenous Health District has been significantly limited. Instead, these workers are used to perform administrative functions, deliver medicine, and conduct general maintenance such as cleaning. The Indigenous movement continues to fight for the cultural and constitutional rights of Indigenous people. Together with its partner organizations, it sets out to improve the health of Indigenous people living in the Rio Negro region, surrounding the region, the role of Indigenous community health agents. Part 3, Intervention and Implementation. In 2007, leaders from the Federation of Rio Negro Indigenous Organizations approached academics from the Oswaldo Cruz Foundation. They requested support in professionalizing the role of Indigenous community health agents in the northwest Amazon region of Rio Negro. The upper Rio Negro, covering 75% of Indigenous lands of the Rio Negro region, has a population of 38,000 Indigenous people spread through 600 villages spanning over 12 million hectares in the Amazon region. There are 19 multi-ethnic and multilingual groups who are distributed widely across the area. Indigenous community health agents play an important role in caring for these remote communities and are often the only providers of health care. The Indigenous still suffer from discrimination in Brazil, being considered inferior. They want recognition of the training because it seems that all the knowledge that Indigenous health workers have is not worth it. The focus now is to make government institutions recognize the specific training the health workers received and that they can sign documents for this. This was an Indigenous leader quote. As stated in multiple Brazilian status and acts, the envisioned role of Indigenous health agent is to have adequate skill and knowledge to care for their communities and to act as a link between traditional knowledge and biomedical health systems. It's further expected for them to conduct home visits, perform health promotion and disease prevention activities, and collect data for health information systems. However, numerous challenges have affected the implementation of these role expectations. There has been minimal training and development. From 1990 through 2006, AIS received 12 short training courses offered by various institutions. So AIS, I guess, is the Indigenous health people. Lack of culturally appropriate training. None of the courses that were offered took into account local culture, ethnicity, or language. All courses were limited to biomedical training. Lack of secondary education. Only 20.9% of AIS have completed secondary school, thus preventing them from enrolling in official mid-level technical accreditation courses. Top-down implementation. Most programs, interventions, or activities designed and implemented in Indigenous communities have followed a top-down approach, reinforcing colonialist histories and disregarding the contributions of Indigenous knowledge. In response to these challenges, the Federation of Rio Negro Indigenous Organizations approached a team of academics and researchers at the Oswaldo Cruz Foundation to assist. The team members, Luis Granello, Ana Lucia Pontes, and Soli Sampiao, set out to develop the first formalized training program tailored to the contextual and cultural realities of Indigenous communities. The intended outcome of the training program was to produce mid-level qualified Indigenous health workers who felt responsible for the communities, whose communities feel confidence in their problem-solving ability, and who can advocate at the institutional level for recognition of the role that Indigenous health workers play. The first program ran from 2009 to 2015, training 189 Indigenous health agents. Several elements differentiate this program from other programs implemented in Brazil. First, multidisciplinary collaboration and participation in participatory community design. The curriculum design took shape through a 2-year consultative participatory process from 2007 to 2009 and involved all relevant stakeholders from state, municipal, and community levels. These included a multidisciplinary group of anthropologists, medical doctors, traditional Indigenous healers, and education specialists. This proved vital to ensure the program did not reinforce a colonialist approach, but rather acknowledged the voices of Indigenous stakeholders throughout all its aspects. Workshops brought together existing Indigenous health workers, teachers, and Indigenous leaders. Due to differences in language and cultural nuances, representatives from each community were included. Support for the program was received at the state and municipal level from the Ministry of Education and the DESI, which is the Indigenous Health District. Next, it says, place-based education supported by bidirectional teaching and learning approach. The team adopted a place-based teaching learning approach where there was bidirectional learning so that the teaching was influenced by the learners, that provided the opportunity for the curriculum design and delivery to be guided by the cultural characteristics, political distinctions, language, and geographical differences of the various ethnic groups in the 5 district geographical areas of the Rio Negro. The bidirectional teaching learning approach united theory, practice, and personal experience of the students in order to produce healthcare actions at the community level. Over 72 teachers were sourced, including several from each of the Indigenous communities to account for the community difference. The delivery of the training program occurred within the remote communities. Reaching these isolated areas posed logistical challenges for the implementation team, often resulting in 2 or 3 days of travel via boat or plane. And this is a quote from one of the people who came from the Oswaldo Cruz Foundation. It says, "So it takes a lot of time to get places. In some places, we need to go to the jungle and then go to the river because it's so dangerous. You need a fast motorboat to make it quick," end quote. Building trust and respect of the Indigenous peoples was paramount importance to the implementation team. Once the team reached the designated community, they would remain with the community between 20 to 45 days, delivering training courses 6 days per week. Living with the communities for this extensive time was an important element to build strong relationships with Indigenous health agents, while also being able to tailor the program based on the perceptions and feedback of the community. Quote, here's another one from the Oswaldo Cruz Foundation. "For me, it's fundamental to build strong relations with people by sharing food, feelings, and work. If you talk, share, and try to speak their language, you end up developing a special relationship different from the one built professionally," end quote. The next item that was different in this training was integrated vocational and high school training. Incomplete high school training is a key barrier for the Indigenous health workers to meet the entrance criteria for vocational biomedical training. The training program delivered high school training alongside the vocational training in a stepwise manner through providing 1,800 hours of regular schooling and 1,440 hours of vocational training. High school subjects taught included Portuguese language, mathematics, and science. Next section, blending Indigenous medical practice with biomedical practice. In its approach, the training had to account for the sociocultural aspects, values, and spiritual beliefs of the Indigenous communities. Training then had to complement traditional knowledge with training and biomedical approaches to health and disease. Here's another quote. It says, "It was the first time somebody was trying in a serious way to join tradition and biomedicine in Brazil," end quote. The training program included a wide range of biomedical and public health subjects such as health promotion, disease surveillance, and treatment of disease, common primary care conditions such as malaria, tuberculosis, respiratory infections, and diarrhea. This component of the curriculum was developed for the best practice guidelines of the Brazilian Ministry of Health and the World Health Organization. The training program leveraged the local environment and society as a basis from which to start the training and ensured community interaction at each stage of the Indigenous health agent learning journey. Indigenous health agents were taken through a 3-stage process to integrate knowledge with biomedical knowledge as well as theory with practical action. In stage 1, the focus was on gaining knowledge of the environment and societal life and understanding the traditional way of life, the historical changes resulting from colonization, political dimensions, and traditional knowledge systems. In stage 2, the focus was on analyzing living conditions and health situations in order to promote health surveillance according to the life cycle in the Indigenous context. In stage 3, the focus was on developing a community action plan by incorporating knowledge gained on the delivery of healthcare in a culturally sensitive manner. Next section's called Organization and People. The emergence of, this is the conglomerate of Indigenous organizations that advocate for Indigenous people, dates back to 1987. In the decade prior to this, the Rio Negro region experienced an intensified military presence. Mining companies and prospectors threatened the area's natural and land resources. To provide a single voice for Indigenous peoples for the protection of their land, FORN was formed by using over 60 small, locally structured Indigenous organizations representing 750 communities. The organization invests in conducting various initiatives and projects in support of the challenges faced by Indigenous communities. Fundamental to their approach is the protection of culture, tradition, and general knowledge of Indigenous peoples. The Indigenous Health Agent Professionalization Program was initiated by the Oswaldo Cruz Foundation, Fiocruz, at the request of the FORN. And here's a quote from an Indigenous leader. It says, "This is what happened in the political context of the Indigenous movement. To revalue the health agent. It means that the training of health agents have now a great political importance to the Indigenous movement," end quote. Fiocruz is the National Brazilian Public Health Research Institute established in 1990. The organization represents all regions of Brazil and supports the national health system through health policy formulation, research, teaching, health service delivery, and medical product development. The implementation team from Fiocruz consisted of Ana Lucia Pontes, a medical doctor and professor of public health, Maria Luis Garnelo, a medical doctor and anthropologist, and Sully Sampao is a social scientist. Collaboratively, they combine rich expertise and experience as well as deep passion to improve the health of Indigenous peoples. The goal of these two organizations has been to work together with a larger network, not hierarchy. The collaboration has been extended to all relevant stakeholders and organizations, the Secretary of State for Education and Teaching Quality, the Special Indigenous Sanitary District of Rio Negro, and the National Health Foundation of Health and the Municipal Health Secretariat. Section 5, Cost Considerations. Different funding streams were combined from various organizations in order to support the pilot training program that ran from 2009 to 2015. Strong political financial backing was received from the Ministry of Education in support of the high school training delivered to the Indigenous health agents. Local health districts and Fiocruz provided funding and materials for teachers delivering the health component of the training. The biggest cost consideration for the team was the transport and living costs of the Indigenous health agents and their teachers during the course delivery. All of the professionals involved in teaching belonged to public institutions that supported the program at no cost. It's estimated that the total cost of the project was approximately $29,000 per year. Section 6, Outputs and Outcomes. The Indigenous Community Health Agent Professionalization Program has experienced positive changes in several areas as determined by the program monitoring process. Due to the lack of strong health information systems, in the Rio Negro, the team has not been able to assess the impact of the program on health indicators of the community. The final training module was completed in mid-2015. From 250 agents who qualified for enrollment, 198 participated in the program, and of those, 139 agents, which is 70%, completed the full training program. These agents gained competency in screening for disease, like malaria, tuberculosis, and other infectious diseases, and were skilled in caring for pregnant women and children under 5. And this is a quote. "They are the only 139 health workers with professionalization in Brazil. It makes them proud, end quote. Secondary school completion increased from 20.9% to 84% among the Indigenous health agents. Indigenous health agents also reported that they have felt valued by the training process, their confidence in their work has increased, and they're now able to actively participate in the delivery of services. This is a quote from an Indigenous health agent. It says, "We learned about culture, politics, how to value food, and the treatment of water. In the communities, people thought they only knew about diseases and how to administer medicines. But the course allowed us to learn about health, how to care for the community health, and how for them not to get sick," end quote. The program has achieved its political goal of increasing recognition for the role of Indigenous community health agents. The qualifications gained on completion of the education program has enabled these health agents to receive a salary for the work they do. More work is required to gain full official recognition for them from the national health system. Next section, sustainability and scalability. The program was developed and implemented as a pilot project. The implementation team has been consolidating the experience and knowledge gained. As researchers, their goal has been to share the knowledge with others through gray and academic literature. A second important aspect of ensuring sustainability has been advocacy and uniting of various stakeholders. Since inception, the team has hosted regular assemblies with the goal of strengthening relationships and support for the Indigenous health agents at a national level. To support the upscaling of the program, several considerations need to be taken into account. First consideration is contextualization. Within the wide variety of culture, language, and ethnic differences between different Indigenous groups, it'll be necessary to adapt the program according to context. Evaluation. In the absence of a formal program evaluation, the implementation team will need to build further linkages with other academic institutions to support evaluation. Funding. The pilot program was financed by research grants, but it will require more sustainable funding in order to scale it beyond the Rio Negro region. And finally, political support. The program hopes to achieve a national policy for workforce training for the Indigenous health system. Section 8, implementation lessons. Getting started. Building trust with and getting commitment from the community through communication, collaboration, and inclusion has been vital for securing initial support from local and government and non-governmental organizations. The strong political will of FIORN, which is the group of Indigenous organizations, catalyzed progress for this partnership. The Fiocruz team's long-standing academic expertise and collaborations were central to obtaining funding and the implementation of ICHAP. Maintaining efforts. With the main implementation team members being resident in academic institutions in different cities in Brazil, the presence of the field coordinator and researcher, Sully Sampao, was an essential investment to the program's smooth running and success. Mr. Sampao often traveled to the communities, a remote flight, and then sometimes a further 4-day journey by boat, and stayed for prolonged periods of time to support the Indigenous health agents with any challenges they may encounter. This helped develop trust and strong relationships with the Indigenous communities. Overcoming challenges. A number of obstacles complicated the program's implementation. 1. Vast geographical spread of the communities gave the program some unique logistical challenges. Next, different political tensions existed among the various Indigenous ethnic groups. Where possible, the team tried to find teachers and tutors of similar backgrounds for the Indigenous health agents of each ethnic group. Next, sickness and personal situations arose where some Indigenous health agents needed to take time off from their modules and go back to their communities. Costly transport and care had to be arranged for them to make the long journey back and forth, and to catch-up arrangements had to be considered when they returned. Flexibility and strong regional partnerships were central in responding to these challenges. Next, some of the Indigenous health agents did not complete their training for a variety of reasons. And here is a quote from somebody from the Oswaldo Cruz Foundation. It says, "Some of them were local chiefs, and the people were upset with them because they would be absent for long periods. We had old people who had no problem in continuing being health workers, but it was harder for them to keep up with all the reading and studying required to achieve the medium level. But most of them made it to the end of the course." End quote. Next section called Case Insights. 1. In countries with marginalized or distinct cultural population groups, a deep understanding of their values and beliefs toward health and well-being provide insights into how health systems should be adapted or redesigned to allow for culturally respectful care that is truly person-centered. 2. Traditional health systems should not be neglected or undermined. Instead, the value of traditional community knowledge can be leveraged and integrated along with biomedical approaches in a structured and cohesive way. The end.